Welcome to this explainer. I am super excited to have you here today. We're going to put on our medical detective hats and explore a truly fascinating area of medicine, exactly how doctors evaluate cognitive decline. We'll be looking at how they act as medical detectives, hunting for hidden clues that might just turn an overwhelming diagnosis completely on its head.
Okay, let's dive into this. Picture this scenario. A 63-year-old woman is brought into the clinic by her daughter. For about 6 months, she's had this worsening forgetfulness. She's missing appointments, repeating questions, and getting lost on a route she's literally driven for 20 years. Before the doctor has even examined her, the family's first word is dementia. But that brings us to the absolute critical question every doctor has to ask themselves when they hear that word. Has anyone actually looked for something reversible yet?
To get to the bottom of this, here is our clinical roadmap. We'll start with not always Alzheimer's, move to the 4-step framework, then hunting for mimics, look at bedside subtyping, and wrap it all up with a diagnosis of exclusion. All right, let's get into it.
Section 1. Not always Alzheimer's. The trap of the label.
You know, a really meaningful fraction of so-called dementia referrals aren't neurodegenerative at all. And the stakes here? They are incredibly high. Listen to this. If you skip the workup and jump straight to Alzheimer's, you can miss a problem you could have fixed. Literally, labeling someone too early isn't just some minor administrative error. It can absolutely rob a patient of a reversible cure.
Section 2. The 4-step framework. This is the non-negotiable clinical sequence that serves doctors on every single ward round.
And this brilliantly illustrates the strict medical protocol required. Step 1, gather the history and collateral info. Step 2, a focused cognitive screen. Step 3, targeted labs and imaging. And Step 4, making the critical distinction of reversible versus neurodegenerative. If you skip a step here, you're either over-testing an obvious case or, far worse, under-testing someone who desperately needed it. So let's zoom in on Step 1. The reality is, a doctor almost never gets the full story from the patient alone, right? They get it from whoever lives with them, that's the collateral history, and they're hunting for two massive clues here. First up is tempo. Was this a slow drift over years or a rapid onset over just a few weeks? Because rapid change? Huge red flag. Second is pattern. Did the memory go first or did their personality totally change before the memory slipped? You add a rigorous check of medications, alcohol use, and exposure risks to that, and boom, you've got the foundation of your investigation.
That takes us to Step 2, the cognitive screen. Doctors have a few really neat tools at their disposal here. The MMSE is super familiar, but honestly, it's pretty insensitive to early frontal lobe issues. The MoCA, on the other hand, is fantastic because it's sensitive across multiple domains: memory, language, attention, the whole shebang. Now, if time is incredibly tight, the minicog is the fastest, just 3 words to remember and a clock drawing test. But here's the absolute key takeaway for this step. The goal isn't to make a diagnosis yet. The goal is simply to map out which cognitive domains are actually impaired.
Section 3. Hunting for mimics. Time for the medical detective work to rule out the treatables.
So the crucial point is this: before a doctor ever slaps a neurodegenerative label on a patient, they absolutely have to run a core lab panel. The strictly non-negotiable tests: thyroid function, or TSH, and vitamin B12. It actually surprises a lot of patients, but hypothyroidism and B12 deficiency are classic, incredibly common, and completely reversible causes of cognitive decline.
Now, I really want to pause on this specific clinical pearl for a second. Vitamin B12 deficiency can present with cognitive change way before anemia ever shows up on a standard blood test, meaning a normal hemoglobin level does not clear your patient of a B12 deficiency. No way. It is a super sneaky mimic, so doctors literally have to test for those vitamin levels directly.
Beyond that core panel, doctors have to add targeted testing based on the patient's specific risks. For instance, HIV-associated neurocognitive disorder is a very real, often totally under-considered mimic, especially if a patient's status isn't known. Doctors also need to test for syphilis, which is literally called the great imitator in medicine. They'll start with an RPR or VDRL screen, and if that's negative but they're still suspicious, they confirm it with a specialized FTA-ABS test. Missing these is a massive real-world risk. We're not just talking theoreticals here. But, sometimes blood work just isn't enough, and that triggers the need for a CT or MRI scan. The specific scenarios listed here absolutely demand immediate imaging. So if the onset is under 65, if the progression is really rapid, if there are focal neurological signs, a recent head injury, or if the patient is on blood thinners, imaging is 100% essential. The doctor is hunting for structural causes, like normal pressure hydrocephalus or a slow brain bleed called a subdural hematoma.
Both of these can totally mimic dementia, and both can actually be treated.
Section 4. Bedside subtyping. Let's look at what happens when the labs finally come back.
Let's move to and see how this builds. In medicine, we love to sort things into buckets, right? Bucket 1 is our reversible treatable mimics. If you find a thyroid issue or an infection, you treat that first and reassess their cognition later. Calling someone demented before treating those issues is just a massive disservice. But if the workup comes back clean and the decline persists, then the patient falls into bucket 2, neurodegenerative diseases, and that is exactly when it's time to figure out which specific one we're dealing with.
A highly skilled clinician can actually spot 3 men clinical signatures right at the bedside, way before specialist imaging even happens. You've got the slow, memory-first pattern of Alzheimer's, the stepwise focal sign pattern of vascular dementia, or the early onset personality-first presentation of frontotemporal dementia. Let's break those down a bit, starting with Alzheimer's disease. This is your classic amnestic pattern. Short-term memory is typically the very first thing to go, and it's a slow, steady, heartbreaking progression. But interestingly, the patient's personality usually remains fully preserved early on. However, they are often what we call insight blind, meaning they honestly don't realize how impaired they are. Things like word-finding difficulty and losing track of time, those usually follow a bit later. Vascular dementia, though? Totally different tempo. Instead of a smooth decline, it's stepwise. You'll see sudden, sharp drops in cognitive ability, often right after clinical or silent strokes, followed by plateaus where things just stabilize for a bit. A doctor will be looking out for focal neurological signs, really severe issues with executive function, like trouble planning things, and a deep vascular history, like hypertension or diabetes. Now, what's really interesting about this slide is this specific phrase: he's just not himself anymore. When a family says that, doctors immediately need to start thinking about frontotemporal dementia. This is the subtype most frequently missed by residents. Why? Because memory is actually often totally fine early on. Instead, it's the personality and behavior that change first. The patient might become impulsive, suddenly apathetic, or start saying wildly inappropriate things. It also tends to hit earlier, often before age 65. Simply put, if the personality goes before the memory, you're likely looking at a frontal lobe issue, not a hippocampal one.
Section 5. A diagnosis of exclusion. Bringing it all together.
All right, let's bring this all the way back to that 63-year-old woman from our cold open. Before any doctor grabs a pen and writes dementia, likely Alzheimer's in her chart, an exact, non-negotiable checklist has to be completed. You got to get the collateral history, run the proper cognitive screen, send out the labs for TSH, B12, and, where relevant, HIV and syphilis. Image the brain if anything at all looks atypical. Only after all of that is perfectly clear do you let the bedside pattern guide your subtyping.
And that brings us to the central, undeniably crucial thesis of this whole explainer. Dementia is a clinical diagnosis of exclusion just as much as it is inclusion. Every single time a step is skipped, it is a missed opportunity to give someone their mind and, frankly, their life back.
So, I want to leave you with this final, powerful question to really reflect on. What if what looks irreversible isn't? The stakes of a proper medical workup absolutely could not be higher. I really hope this explainer has empowered you with a clear understanding of exactly how medical professionals tackle cognitive decline and why ruling out these mimics is the most important step of all. Keep asking questions, keep looking at the data, and keep learning. Thank you so much for joining me today.